Hey, what's up, guys? Welcome back to the podcast. Today, I've got a special guest with me, Dr. Coleman Westerby, and today we're going to be diving into the topic that is way too commonly misconstrued in the fitness world, which is pain science. And we're going to go over how it's often misunderstood, misapplied, and sometimes completely butchered by the industry. Today, we're breaking down a paper by Dr. Eric Trexler called The Re-Miseducation of Pain Science in Fitness. In the paper, he goes over his own journey about chronic pain and how well-intentioned but ultimately misleading advice made the situation worse. We'll go over what modern pain science actually says and how we should be applying it in coaching, training, as well as rehab. So let's get in. Let's start with the basics. So the old school pain model was super simple. You get hurt, you feel pain, and when it stops, it's because the tissue was healed. This is the Cartesian model or biomedical model, where pain is strictly tied to the mechanical damage. But research has shown that chronic pain doesn't really work like that. There's a new understanding of pain, which is represented by the biopsychosocial model, which says that pain isn't just about tissue damage. It's also influenced by our emotions, our mindset, environment, past experiences. So in other words, pain isn't just about the body, it's also about the mind as well.
The biopsychosocial model breaks pain into three main categories. And so one of those is biological factors. So that is tissue damage, inflammation, stuff like that. And then it works into psychological factors. So how you are perceiving your pain, and are you in a depressed state, so on and so forth. The third factor is social factors, which is environment, lifestyle, who you hang around, and all this kind of plays into how your pain is experienced.
So when someone experiences chronic pain, it's not just about healing tissue, but it's also about addressing all these other factors that Coleman just mentioned. So this explains why two people can have the same MRI results and have completely different experiences.
Yeah, and that's where things get tricky. So in the fitness industry, they took this new pain science model and they kind of ran with it. They went in the wrong direction for the most part. With that being said, a lot of people are starting to say that, hey, your pain is just in your head, so on and so forth, or hey, your pain has nothing to do with your actual injury, which can be from lumbar radiculopathy, where you have some leg pain, but the pain is actually coming through your back. So all in all, they have taken this bit of information and kind of twisted it a little bit. And so it's definitely true in some cases, but not all cases.
Exactly. So Eric Trexler talks about how during his 7-year battle with chronic pain, he got hit with a ton of expert advice that were based on some real pain science, but also misapplied. I guess honestly, this section right here, I could probably just not talk about the paper, and I could just talk about how a lot of the industry is, right? You get a little bit of data, a little bit of science, and then it gets twisted and misapplied, and then becomes a myth that lasts for the next 10 years. So a real world example is you can get abnormal imaging results that don't necessarily mean pain, which is true. Plenty of people have herniated discs or meniscus tears with zero pain, but that doesn't mean we need to ignore imaging altogether. If an MRI shows something that's abnormal and it matches your symptoms, it's probably relevant.
Same thing goes for movement abnormalities or asymmetries. So a lot of people say, oh, asymmetries don't matter, or they really do matter. Nonetheless, if we think of elite athletes, these guys and girls are the masters at asymmetries. That's why they can do amazing things with their body. So, but nonetheless, in the study, Trexler kind of talks about how his worsening pain was coming from these asymmetries. So, nonetheless, while asymmetries are not the all be all and it's, oh, something's going wrong, it can be indicative of some bigger sources of pain. So in Trexler's case, when he was talking about his worsening hip pain and his pelvic pain, while asymmetries can play into that, a lot of the times they do not, but nonetheless there can be some clinical factors that kind of stray you towards, hey, these asymmetries need a little bit deeper dive. What's causing them? Why are they being caused? And so on and so forth.
Exactly. So if you have an obvious movement asymmetry, like if you squat down, your pelvis turns 90 degrees, it's 100% something you should actually address and not something that's just all in your head.
Yes. Another thing that comes out of this is a theory called the Fear-Avoidance Model. And so this is a big model that talks about an experience where somebody has a pain stimuli. After that pain stimulus, they have those three factors from the biopsychosocial social model, where there's some biology, there might be a little bit of tissue damage, there might be somebody that was watching you squat and said, oh, you did have a tweak. And then you're thinking, oh my gosh, I did hear a pop, so on and so forth. Nonetheless, they fear that movement again. They don't do their squats. They get weaker. they aren't able to do as much weight, so on and so forth. And then ironically, that pain can get to, and actually it typically does get worse.
Right. And that's where reframing pain really comes into play. So instead of saying my back hurts because I have a bad back or deadlifts are a dangerous exercise, we can shift the narrative to be my back is just sensitive right now, but movement will help me build back more resilience. But, and this is the key, just reframing your pain isn't really enough. If there's an actual injury or mechanical issue that's causing it, the pain is real, right? It's still there. So just like maybe a nerve entrapment or something like that, there could be a legitimate issue that causes you to have a surgical intervention to fix it.
Yeah, and that's where this misinformation comes into play, where people have something that they hear click or pop in their knee or back during a squat, and then they just oversimplify this and say, "Oh, it's nothing." They still continue to have pain. They'll say, "Oh no, it's just kind of in my head here," and they kind of downplay it. In reality, there probably does need to be some further workup and maybe assess some of the mechanical side of things. Is there some joint that's locked up in the back that you can increase, or is your hip locked up where you could do some joint mobilizations, stuff like that, so you can have a better squat form and prevent that pain later on.
So now how do we actually apply this to training and coaching? First off, we need to stop blindly throwing pain science buzzwords at people and expecting them to get it, right? We need to start listening to their actual experiences. If a client has chronic pain, we don't just say, pain is just an output of the brain, it's all in your head, stuff like that. We need to actually assess what's going on, mechanically, psychologically, and behaviorally, just like the biopsychosocial model.
That's very right. And so there needs to be a balance in between optimism as well as reality. So yes, the body is very resilient. Majority of the time, things will kind of just get better on their own. But nonetheless, there are those situations where people really do need some mechanical intervention, some imaging, and unfortunately, sometimes they do end up with surgery.
100%. And as coaches, we should be teaching people how to move well, train smart, and also how to manage pain without catastrophizing it. We see too often people just catastrophize their pain into oblivion. We want to make sure we prevent that. That means giving them realistic frameworks to follow by scaling them back intelligently, finding them a pain-free entry point. So let's say in a squat, going down to a box squat, and then progressing them over time.
Yeah, a lot of times we've had it multiple times in the program here at Aspire Fit, where a client tweaks their shoulder, something in that nature, and they kind of get this catastrophizing mentality where, oh my gosh, I'm done. They ask, hey, can I put the program on pause? Can I stop the program? So on and so forth. In reality, the best thing that they should do is continue with the program so we can scale them back a little bit. We can find those pain-free entry points, as well as start progressing them over time and getting them back to where they were. Now, there are times, and you and I know this quite well with clinical work as well as working in the physical therapy realm, is we do need to know when to refer out. And so maybe that's another aspect of the Aspire Fit program, and where people shouldn't just jump ship, is that we can help guide them into the right steps. Hey, how do you go to your primary care provider? How may you get direct access in your state for physical therapy and stuff like that?
All right, so let's wrap this up. So the big takeaways are that pain is complex. It's not just mechanical, and it's not all in your head, right? The biopsychosocial model is pretty useful when it's applied correctly instead of just being misapplied. So if you're dealing with chronic pain, don't just get trapped in this fear avoidance cycle where you just stop doing everything completely, but also don't ignore the real mechanical issues that are going on. You need to train smart, assess properly, and when in doubt, get a second opinion from a professional who actually knows what they're talking about and actually listens to you.
Yes, so this is the challenge to all you coaches and trainers. Definitely be better than those pain vigilance online that are just throwing out, oh, it's in your head, just keep moving, just modify this and that, and be individualized. Ask your clients, hey, what bothers you? When does it bother you? And always, always, always be humble enough to refer out and give them the proper guidance. So a good thing with chronic pains like this, if we're just we're not finding any relief when we're trying modifications to lifts, we're finding new entry points, and it's just not working. The first thing that I always recommend my patients in the clinic, and I have recommended some of the Aspire Fit clients, is a book called Why I Hurt by Adriaan Louw, who is the best of the best in the pain science realm, especially with that psychological component of is it all in your head? This book kind of walks you through on, hey, is it or is it not? So that's a good starting point. And I think we are going to have a description of that or a link where you can find that book.
Absolutely. So it'll be in the description, the show notes, wherever you can find the link, wherever you guys are watching this video at, whether it's YouTube, Spotify, whatever. And that's it for today's episode. So if you enjoyed this deep dive, go ahead and subscribe, leave us a review, tag us on Instagram at dr.benpetersen and dr.coleman.dpt. And if you're interested in working with us at Aspire Fit, there's going to be a link in the show notes description to apply for coaching. And also, if you're interested in articles like this from Mass, I will also leave a direct link for Mass if you're interested. So that's it. See you guys later.